Good afternoon, everyone. So Lunch with Rita is back. We will wait for 1 or 2 minutes, the time that people can connect. There are about 230 people that are recorded to join the meeting today. So as you know, all these webinars are recorded and can be seen afterwards. I should also say Happy New Year because it is the first webinar of the year. Wish you a lot of happiness. And so today we restart this Lunch with Rita session dedicated to this ERN and trying to cover all the different streams, including immunodeficiency, autoinflammatory disease, pediatric rheumatology, and vasculitis as well. So here today we have a fantastic disease that will be presented by two talented immunologists and clinician scientists, Isabelle Meyts and Sophie Georgin-Lavialle. And it seems that it will be a real duet altogether that will present the different aspects of this fantastic disease, the new data that was generated last year. And I hope you will enjoy. It will be in some part interactive normally, so you can vote. And you can also ask questions directly in the chat. And to finish, I can just ask you if you personally are interested to present something across the different stream for the RITA community, please ask us. We have some available slots still to present this Tuesday lunch with RITA webinars. And again, thank you for joining. And now I ask Isabelle and Sophie to start the presentation. So Isabelle, Sophie, the stage is yours.
So thank you very much, Alexandre, for inviting me with Sophie to present this seminar or this webinar on ADA2 deficiency to you. And as you will see, we will give you an overview about the recent knowledge on pathophysiology, manifestations, clinical manifestations, and treatment. And we will look at this from a pediatric point of view, but also from an adult medicine point of view. Next slide, please. Next slide. So as you may know, the first papers on ADA2 deficiency date back to 2014. And there were two New England Journal of Medicine publications back to back on this novel condition. And if you read these papers very carefully, you will see that a lot of knowledge is really incorporated in these papers. But basically, it came down to the presentation of polyarthritis nodosa vasculopathy and or lacunar strokes, but also features of lymphoproliferation and immunodeficiencies in patients with in fact, biallelic deleterious mutations in, at that point, still the CECR1 gene, but now called the ADA2 gene. And so while many of you may already know this disease, we would like actually to tickle you a little bit and to get you all woken up with a few introductory questions that will be presented by Camille. Can we switch to the quiz, please?
Yeah. So you have to click true or false very quickly. We will just have 2 minutes for the quiz, and you have about 10 for this. You have about 40 seconds for this 4 quiz, and after we will have more quiz. Camille, can you check if people already voted? So I will read the questions and then we will go to the next quiz. So all DADA patients have the same clinical phenotype, yes or no? Bone marrow failure and cytopenia can be part of DADA2. True or false? A normal DADA2 activity always rules out DADA2. TNF inhibitors markedly reduce the risk of new ischemic strokes in DADA2. So next quiz. Okay, so we can check. Well, we will have the answer at the end.
Okay, so Camille, you can present the next slides, please.
Oh, yes. So we have a few more quiz, Isabelle, before the next. So, yeah. Camille, you can put again the clinical quiz. So, clinical presentation. In children, DADA2 can present with early lacunar strokes. True, false. Adults with DADA2 can be misdiagnosed as having Sneddon syndrome or periarteritis nodosa. Adult DADA2 patients frequently have long diagnostic delays. True or false? So we will go to the last. We have 3 more quiz. I think we can go to the next, Camille. So this is genetic and pathophysiology. DADA2 is usually caused by B-allelic loss of function variants in the ADA2 gene. Residual ADA2 activity is more often associated with vasculitic phenotype than with severe bone marrow failure. 10 seconds, and we will go to the next quiz. Okay, we can skip, Camille. Most reported DADA2 patients have childhood onset symptoms. Please answer, and we will discuss about this. Most DADA2 patients have childhood onset symptoms. True, false. And then go to the last. Camille. Last quiz. Okay, these are the last ones. TNF inhibitors are the first-line treatment for vasculitis stroke phenotype. Yes or no? Conventional immunosuppressants alone are as effective as TNF inhibitors for stroke prevention. HSCT is the only proven curative option for severe marrow failure. And it's generally considered for severe cytopenia or bone marrow failure. So in 5 seconds, we will stop the quiz. Okay, Camille, we can go to the next slide. Thank you for participating.
Okay, and so back to the introduction. So you're all warmed up now. And so basically, one of the this already gives an answer to several of the questions you saw previously. So in the New England paper that was published by the NIH group with Dan Kastner and Ivona Ksentijevic, you can see that all of these features are actually already present in the little cohort of 9 patients that they were describing. And so we will go back to all of these features from a pediatric point of view, but also from an adult patient point of view. Next slide, please. And this is the same as the previous one, so you can move on. And then we go to the clinical features. So depending on what paper you're looking at, there are several large cohort studies out now. One of the first ones was the one that I published with Ivona back in 2018. But if we look at the updates right now, basically, by and large, the presentations and the manifestations seem to be about the same in terms of percentages and in terms of severity and so on. So what is very important is that in children, you have, let's say, an early presentation for most of the papers we are looking at. There is a wide range, and Sophie will stress the let's say, the delayed diagnosis in many of the adult cases and an early onset, nevertheless, and an unrecognized disease. So the median age can be at presentation about 3 to 5 or to 7 years, depending on the paper you are reading, but it seems to be an early onset disease, at least from a pediatric point of view. And also what is important is that several of the patients presented at birth with symptoms of ADA2 deficiency. Now, looking at the symptoms and manifestations, these are quite diverse. And let's say they can be broadly divided in vasculitis or vasculopathy manifestations, immunodeficiency, and hematological manifestations. So if we look at the different manifestations, what is important is the cutaneous manifestations with livedo as a very prominent feature, but also the polyarteritis nodosa features that were very prominent in the initial presentations and descriptions. But also looking into neurological manifestations, these are very important and need to be highlighted also to the neurological and neurologist community. As you see, up to half of the patient really presents with neurological manifestations, which can range from polyneuropathy to ischemic lacunar stroke. Also, I want to stress the immunological and hematological manifestations. As you see, almost 50% of the patients deals with this. And it's important to recognize that hypogamma or common variable immunodeficiency can be a presentation of ADA2 deficiency, but also any kind of cytopenia, be it autoimmune, be it bone marrow failure derived, pure red cell aplasia, anemia, thrombocytopenia, or neutropenia. So hematologists really need to be aware of ADA2 deficiency as an underlying condition for these diseases. I also want to highlight end organ manifestations, for instance, the GI tract. So vasculitis of the intestinal tract, liver disease is very important to realize. And also frank intestinal necrosis has been described. And I would also like to highlight, for instance, nephrological manifestations with renal artery stenosis and so on. Another important feature, and you can go to the next slide, Camille, is that there's been more past slides. So go back, please. Because I highlighted some of the features that are more being more recognized recently. And this is, for instance, a few papers on HLH as a manifestation and a sole manifestation of ADA2 deficiency, but also lymphoproliferation with lymphoma, with leukemia, and different kinds of end organ manifestations where we are only learning the impact of ADA2 deficiency, even in childhood. So next slide is, I hand over to Sophie.
So from an adult point of view, we have to admit that they now represent a substantial part of reported cases. And what we can see is that we have a few really adult onset disease, but most of them have adult with a childhood onset disease with a very delayed recognition. And when we ask the patient about their childhood history, or we ask their parents, or we ask their brother and sister, all of my patients, they have beginning in childhood, especially with the cutaneous features. So we really need to ask questions about this in order to decrease the delay diagnosis. Next slide. So when we compare in all the published cases, the age at onset versus age at diagnosis, there is a systematic review on almost 400 patients. The mean age at onset is about 7 years, and patients are very few with the first symptoms after 18 years old, only less than 30%, and about 1/4 of them had after 10 years old. In a large comparative cohort, we found 140 diagnosed in adulthood versus 143 in childhood, and many adult cases were at a pediatric onset with a large diagnostic delay. So next slide. Also, what we can just say for adult patients with a large diagnostic delay, the typical presentation can be recurrent lacunar stroke before the age of 50. So neurologists should be aware of this disease. also what used to be called a Sneddon-like disease. In the past, we called it like Sneddon, but if you have a patient with a Sneddon disease, I think you should look for DADA2 deficiency if you're an adult, especially without antiphospholipid antibodies. And also for a primary central nervous system vasculitis or cryptogenic stroke. Also, in any pan-like vasculitis with atypical feature like abdominal pain, elevated inflammation, you should look for the disease. And also, if you have a chronic systemic inflammation with any of the above written features, you should look for DADA2 deficiency. Next slide, please. So a few pictures of adult patient. This lady, she had the livedo of the leg. You can see it. It was going until the knees. And a brother died of DADA2 deficiency, and he had livedo going until the trunk. And they had this since they were children, but the diagnosis in her was done at 43 years old, and she had a stroke, and now she's under TNF inhibitors. Next slide, please. So a few pictures from literature where you can see livedo. We will go on in adults. We can go to the next slide. This is another classical adult discovery of a patient with chronic ulcer of the lower lip that cannot be treated. And then you will find DADA2 deficiency. And then when you look more at the skin, you can see livedo on the trunk or on the abdomen. Next slide. This is very classical with the stroke. Next slide. This is a published case from the series of the NIH with another kind of stroke that you can see. Next slide. So from the NIH cohort, what was interesting is that the distribution of the stroke show that it can be deep or also in the brainstem or cerebellum. Next slide. And this is another interesting feature from the NIH cohort with the muscle infiltration with myositis on the MRI. Next slide. So to finish with the adult clinical presentation, as Isabelle said, humoral immunodeficiency is frequent, but with not so many severe infections. And when the diagnosis is performed, usually in the past, the adults were labeled CVID-like and not spectacular infections. And also, as Isabelle said, some lymphoproliferative disorders or immune dysregulation, like autoimmune cytopenia and ALPS-like picture. Next slide. A few adult patients can be diagnosed in front of a pure red cell aplasia or atypical DB-like anemia and all the cytopenia, and a few evolutions, as Isabelle said, with HLH, like in the Dutch cohort, and a few aplastic anemia or unexplained cytopenia. So next slide. What I only want to say is that the adult phenotype is dynamic, and the three phenotypes are not totally separated. And in the same family, you can have one patient with the periarteritis nodosa, and one of the sister can have the hematological disease, and another sister can have the more CVID-like disease. So we have to, I think, check all the brother and sister whenever a diagnosis is performed. Well, I will say in my adult patient, but also I think in pediatrician, Isabelle will say. And I think this is my last clinical feature slide. Next slide, yes. Isabelle, do you want to say something else about the clinical feature?
No, I totally agree, Sophie. I think it's for children sometimes indeed very unimpressive to see how few infections they have and how the severity of infections does not correlate with the degree of hypogamma they can have. So that's quite striking. And maybe another feature for children is that they may experience quite prolonged viral infections. We've seen a few with severe COVID, for instance. We've seen a few with severe RSV and adenovirus, and also with herpes virus infections. and several with warts that are refractory to treatment. So those maybe can also be additional infections that should highlight maybe to think about ADA2 deficiency. Otherwise, nothing to add. Thank you.
So for the epidemiology, it will be short and visual. You can go to the next slide. So I performed cartography of the reported cohort worldwide. So there are several big cohorts, like in the NIH, like in Europe, also in India. But you can see that some patients were reported in many of the countries. And what I can say is that you don't see any reported cases in Africa, but I'm sure there are. I even know patients from North Africa that are reported because they are living in France, but they are originating from North Africa. And I didn't see Australian reports, but maybe there are. And I think it's because they have less access to the genetic testing in Africa. Maybe Isabelle, you want to comment on this. It's very cosmopolitan disease. That's why I wanted to show this map.
Yeah, I totally agree. It has to do with registration because several of the patient cohorts have just not been published as such or are less visible. And for instance, Australian patients, definitely South America. So it's really a global disease. It's not confined to any region, although some variants are very frequent in specific areas, as we will see hopefully later.
Okay, next slide. So there are about 600 published patients across systematic reviews and cohorts. The biggest cohorts mainly come NIH or national regional cohorts like Netherlands, India, China, Saudi Arabia, Turkey, Iran, France. And there are some systematic phenotypic review, but of course, what we can show there have some bias of strong referral and publication bias. We can go to the next slide. And so what we can say was visible on the geographic map, it's cosmopolitan, it's worldwide, and the diagnosis can unfortunately be done at any age, especially because of the diagnostic delay in adults. And also because of the access to DADA2 activity assays and the genetic testing, it must not be accessible everywhere. And also, the disease is not known everywhere, so if you have never heard of it, you may not diagnose or think about it in front of vasculitis, strokes, or immunodeficiency disorders. I will skip except for if Isabelle wants to say something else. Okay, next slide. So what we could see in a few publications comparing children or adults, I think the disease is the same, but if it's made in adults after a very long diagnostic delay, they can have some complication like articular destruction or AA amyloidosis. And next slide. So this is now for Isabelle.
Okay, and I will try to take you through some knowledge about the genetics of ADA2 deficiency and some, let's say, older and more novel insights in pathophysiology. So next slide, please. So usually it's an autosomal recessive condition, as already pointed out by Sophie, and this is the calculated incidence 1 in 222,000 individuals with a carrier frequency of 1 in 236 individuals. If we take all the pathogenic variants as a combined group. So this is a gene that is located on the 22q11 locus, and that's important because it means that there's also deletions of entire exons. So this is a region that is prone to structural variation. And it's a glycoprotein, and that's also important, as we will see later. It's more predominantly expressed in the myeloid line, but as you can see, there's also an important expression of mRNA and protein in, for instance, lymphocytes. Next slide, please. So here I listed for your information a few of the most common variants, at least in let's say in Europe. These are the variants that we see quite frequently. Of course, there's many more. There's definitely more than 200 and probably already now more than 300 described that have been shown to be pathogenic. But these are definitely the most common ones for our region. And what is important, already highlighted by Sophie, there's incomplete penetrance and different expression within the same kindred. And that's important to realize, that it may be difficult to, let's say, attribute disease manifestations to a given variant. Next slide, please. So ADA2 functions as a dimer, that's important to know. And also what you see here is that this is a predicted binding site for nucleic acids, and that can be interesting for the rest of the pathophysiological discussion. Next slide. This is the ADA2 gene with all of the recently described variants positioned there. And as you can see, there's many structural variants, so it's important to realize that you will not catch all of the variants on a straightforward exome-seq, so you might need MLPA to confirm or to make sure that you are not missing any deletions or other variants. Next slide. So the pathophysiology already, since 2014, of course, there is the quest for the pathophysiology of ADA2 deficiency. And I want to highlight here what we know and what we don't know. So basically, most of our diagnosis is based on the fact that there is reduced or strongly reduced to absent ADA2 enzyme activity in the serum or plasma of patients. That's what we use as a gold standard next to the genetic testing. But it can be quite complicated to attribute pathogenicity to this and to link it to pathophysiology, as we will see later. So what we know and what has been, for instance, also published first by Alexandre Belot is a type 1 interference signature, which is upregulated in patients with ADA2 deficiency. NIH published that there is elevated TNF-alpha levels in serum, but also in tissues, and that there is an aberrant polarization to M1 macrophages that leads then to this pro-inflammatory effect that affects the endothelial cells and leads to the vasculitis or vasculopathy phenotype. Next slide. There's also been mentioning of a role for neutrophils with increased netosis in the presence of elevated extracellular adenosine. This has been published by NIH, and also an interesting, let's say, paper that shows that there's increased type 1 interference signaling due to a change in the methylation of some, let's say, ERVs in the endothelial cells due to an increase in the, or a change in extracellular deoxyinosine. But with all of this, in fact, there's many questions. And in the upper right corner, you see the problem here, because ADA2, if we think of it as mostly an adenosine deaminase in the extracellular environment, it doesn't have the optimum enzyme capacities to run this job. So you can see that it's not very capable of doing the deamination in the physiological circumstances. So ADA1 is much better at doing this. And so it's important to put that into perspective and to really keep an open mind to the pathophysiology of ADA2 as we know it. Next slide. And so recently there's been several papers about the potential that ADA2 or the possibility that ADA2 carries a role as a lysosomal protein and that it acts there basically on the lysosomal DNA where it edits the adenosine that is taken up in the DNA structure to inosine, to deoxyinosine, and that this in fact modulates TLR9 signaling. There's another paper that shows that ADA2 is capable of downregulating TLR9 signaling, and that in fact there is a disbalance when there is no ADA2 or functional ADA2 present. So this might in a way sound conflicting, but it could be that this fine-tuning of the function of TLR9 is really crucial in the pathophysiology of ADA2 deficiency. So we need more information on how this exactly works. Next slide. So in our study group, we also found indeed that ADA2 is present in lysosomes, and moreover, we identified low molecular weight ADA2. So a form of ADA2 that is deprived, or let's say without the big glycan tree on the surface, where you can actually see that this low molecular weight is a typical hallmark of ADA2 sufficient cells. And we found that in the many variants we've tested in the meantime, we couldn't find low molecular weight ADA2 in cells of patients with a pathogenic ADA2 variant. So it seems to be that this is present in the lysosome, this low molecular weight, and that this might be the form, we have to prove it further, that is actually running the role of editing the DNA compound or contained adenosine. Next slide, please. What we also saw when looking into deeper into the pathophysiology is that when monocytes, even of patients, develop in vitro into monocyte-derived macrophages, we can see that there's a partial restoration of the ADA2 expression. And that's quite important because, next slide, it gave us the question whether if we could, for instance, modulate lysosomal degradation, if we could maybe also potentially modulate ADA2 expression. And we tried this on several patient cells. And we could see that, for instance, a very well-known lysosomal degradation modifier, hydroxychloroquine, was capable of increasing the ADA2 expression in the patient cells. We took it a bit further. Next slide. And we also gave this treatment, which, as you know, is often given to patients in many autoinflammatory and autoimmune conditions. And we gave this to patients in very deep and long-term cytopenia. Next slide. And we were able to see, as you see in the upper panel, where you see the neutrophils, the peak in the neutrophils twice is actually where we treated the patients with hydroxychloroquine. And we found another patient in Germany who was also treated in the same way, long-term with hydroxychloroquine, and who never actually fell back to cytopenia, as far as we know. So next slide. We also looked in the patient cell under this treatment, and we found that indeed on Western blot, we could find that there was an increase in the ADA2 expression. And this is, of course, a missense variant. Otherwise, it would not be possible to see it. But we saw that, so in fact, the improvement of the patient correlated, at least in this patient, with an improvement of the clinical status and the neutrophil and B cell counts. Unfortunately, the enzyme levels in the blood were not really helping us to see the difference in terms of ADA2 expression and enzyme activity. Next slide. And interestingly, what we found in several cell lines that we prepared, so knockout cell lines and wild-type ADA2 containing cell lines, we saw that there was, in fact, a decrease in the autophagy flux in patients with ADA2 deficiency, and that this was, in fact, restored in the presence of hydroxychloroquine. Next slide. So this is, in a short capture, that we think that inhibition of lysosomal degradation of any kind can increase the expression of ADA2. We tested this with several compounds, and we believe that this hopefully may be an opening to add some additional insight into the pathophysiology of ADA2 deficiency. Next slide. This brings us also to another question, because if we are able to increase a little bit the ADA2 expression, then maybe there's only a slight balance or disbalance that is present to tip from ADA2 sufficiency to ADA2 deficiency. And this is a wonderful paper by Harvard group by Pugh Lee, where he shows that if we look at the continuum of manifestations of ADA2 deficiency, you can see that, in fact, most of the patients or mutations related to pure red cell aplasia and bone marrow failure phenotype, they result in an absence or near absence ADA2 activity. Next slide. And in a graphical way of presenting this, you could think that nonsense mutations, insertions, deletions, and so on are more frequently associated with pure cell aplasia and bone marrow failure phenotype, and so very low to absent residual ADA2 activity in vitro, versus the vasculitis phenotype, where you have more residual ADA2 activity in a hyperexpression system, which would be more in the missense area. But mind you, again, what Sophie discussed and what we also saw in several pedigrees, you can be in the middle with an R169Q variant and have all of the manifestations present in one pedigree, where we don't really explain with this system how it would work. So there is, in my opinion, no clear phenotype-genotype correlation, if I dare say so. Next slide, please. And so this brought us also to the question that some of the variants, and especially here in the upper right panel, I don't know if you see my pointer, probably not, then actually you see that here in the panel A, you see that some of the variants are actually not so pathogenic in terms of residual ADA2 activity. And you might think that it could be as, let's say, detrimental to have a heterozygous state of a very bad ADA2 mutant versus the homozygous condition of a not so bad ADA2 pathogenic variant. So we took this further, next slide, and I will go through this very quickly to be able to see all the rest of the presentations. So we also were struck by the fact that the immunophenotype of carriers of ADA2 variants, pathogenic variants, is quite intermediate to both healthy controls and the offered clinically ill DADA2 patients carrying biallelic mutations. Next slide. And we saw many features of disease in heterozygous carriers in literature. And by the way, already in the first New England paper, there was a carrier that was also having the DADA2 phenotype. Next slide. And so we studied 10 families in our own cohort, and we found that several carriers were, in fact, also ill with DADA2 phenotypes, or at least a phenotype that could fit ADA2 deficiency. And now, Camille, maybe you can go a few slides further, because I want to go to the conclusion immediately. So next slide, please. So next. So what we basically found is that if we look at the heterozygous variants, and several of the variants we tested, and it's now published, you can see that, for instance, a variant like R169Q in a heterozygous state, if you test it in an overexpression model, if you test it in population genetics, it can be associated with actually all of the features of ADA2 deficiency, both in an individual patient, but also if we look at let's say, population biobanks, you can see that this R169Q or the predicted loss of function variants in ADA2 are really associated with all of the abnormalities that we've seen in ADA2 deficiency spectrum. So cranial nerve disorders, ischemic stroke, abnormal liver function, and so on and so on. And so, in fact, next slide. What we propose is that several of the pathogenic variants, and as you can see here, some of these variants are quite prominent in our countries. You can see that they can result in a dominant negative effect on the wild type ADA2 protein, and that this can result, in fact, in an expression of the phenotype of ADA2 deficiency, although the patients only carry one variant. And that is important because not only it will increase the number of ADA2 patients, and that is also important because we need to take this into account in several other perspectives. Because, for instance, in the adult manifestations, we see that these patients typically present later, so not in the early childhood, but more, let's say, adolescence and early adulthood. So it might be important to consider some of these pathogenic ADA2 variants as the cause of ADA2 deficiency. And although I know that there's still a lot of debate around this, I really believe that if we're able to fine-tune why this expresses in heterozygous carriers, we might be able to help more patients. Next slide. And that's it. over to Sophie, unless you want to comment on some of these aspects.
No, it's perfect. So we will go to the treatment. So next slide. So for the treatment, we proposed you that I give the main goals, and Isabelle will speak a little bit more about the hematological aspects. So the goals are to control systemic inflammation, to prevent the severe features such as ischemic strokes and major vasculitic events, and of course, long-term goals to prevent all the organ functions, which are, as an adult, I will say, we always want to preserve kidneys and then marrow failure and malignancy. So we have two therapeutic pillars, TNF inhibitors. They were shown to be effective to prevent strokes. And also HSCT is only proven curative option for severe hematologic immunodeficiency phenotypes, and Isabelle will discuss more about this in a few minutes. So next slide. For TNF inhibitors, they are really the cornerstone of the vasculitic features, especially etanercept, which was shown by a very nice work from Amanda Ombrello, to prevent the occurrence or the recurrence of strokes when you start early. It can also control fever, vasculitis, and most frequently inflammatory markers. There was a systematic treatment review on more than 200 patients showing an overall effective rate of TNF inhibitors almost 80%, especially in the vasculitis features. So there's a consensus in the published guidelines that were proposed by Pewley and collaborators 2 years ago as a first line for vasculitic and Sjögren phenotype at any age. Next slide. There are a few limitations for TNF inhibitors. I will focus on the adult aspects, but they are not sufficient to reverse severe cytopenia, the pure red cell aplasia, and an established bone marrow failure. They cannot repair if there is already structural damages, like old infarcts of chronic microangiopathy or kidney deficiency, like with amyloidosis. And from an adult perspective, they are unfortunately frequently started too late because of the delayed diagnosis. And also some malignancy could reflect more likely disease biology and cumulative immunosuppression, not TNF inhibitors. Next slide. And then for the conventional immunosuppressive, they can be tried. There are some case reports, but they are generally inferior to TNF inhibitors for strokes preventions, especially. We don't have a lot of data on hydroxychloroquine, maybe in the future. IL-6 or IL-1 inhibitors have not shown any efficiency, and sometimes, but I don't have patients with IVIG, but that can be proposed, and Isabelle may speak about this in children for recurrent infections. And maybe next slide. Yes, Isabelle.
So yeah, I do not have much to add, Sophie. Next past slide, please. Previous slide. So because in fact, I totally agree with what you're stating. We don't see a good influence of etanercept or anti-TNF in general on the cytopenias. And also the rest of the sirolimus, etc., is really anecdotal. And several of these patients went on to really have ongoing bone marrow failure, and one patient with Castleman lymphoma presentation actually also went on to have a stroke and frank vasculitis. So in patients with bone marrow failure and cytopenia at this point, and definitely in children, we don't have a good cure. And also in the patient I presented and we published with the hydroxychloroquine, in the end, we couldn't keep the patient on several lines of immunosuppression, and we resorted to stem cell transplantation. So this is the overview of the data we had for 2021. We collected 30 patients from 12 countries. And as you can see, the indications for transplant were, as expected, bone marrow failure, immunocytopenia, malignancy, or and/or immunodeficiency. They were quite young, but also some adults included. And the follow-up at that point was up to 16 years, but with a median of 2 years. And next slide, please. The strong end conclusion is that, in fact, except for previous slide, except for one patient who, unfortunately, patient 24, who died in the procedure, the rest of the patients experienced a quite good resolution of the symptoms and of the cytopenia and all of the other features of ADA2 deficiency. But as Sophie pointed out, the damage that has been done cannot be restored by the transplant also. So, for instance, liver disease and other end organ disease, if there has been already destruction of tissue by the vasculitis, we cannot revert it by the stem cell transplantation. But as you see, the message is that overall survival is very good, and the GVHD and relapse-free survival as well. There is a problem, next slide please, is that for the 30 patients, we needed 38 transplant procedures. So there's a high risk of graft failure. The slides are moving back, please. And so at this point, we really don't know why this is, but it seems to have to do with low stem cell dose and probably also with incomplete T cell depletion of the recipient prior to transplant. And so what we believe now, next slide, is that we definitely need good lymphodepletion with ATG or alemtuzumab, sufficient stem cell dose, and probably a critical level of donor chimerism. So the optimal conditioning regimen, we really don't know at this point. And it's important to be aware of early graft failure, but also of late graft failure. And to be important also is really watch the end organs, as there may be already significant disease in these patients. Next slide, please. Who to transplant, as already pointed out by Sophie. So patients maybe with breakthrough fevers and vasculitis despite adequate anti-TNF. Let's hope we find a better cure for these patients and the stem cell transplant, but definitely the bone marrow failure phenotype. As soon as it sets in, I think it's important to transplant to not be in a fibrotic marrow. Next slide. This is on the horizon, and we all hope for a smooth delivery of the gene therapy, and we are hopeful because 2 centers in the world are really focusing on this as a corrective treatment for ADA2 deficiency without the burden of stem cell transplantation. Next slide. Back to Sophie.
So we have unmet needs, especially as said by Isabelle, patients with severe bone marrow failure or mixed vasculitis and hematological disease not controlled by TNF inhibitors. So we are hoping that in the future, the gene therapy can be effective, and maybe in the future we can, but we don't have a lot of data on recombinant DADA2. And maybe the most important focus at the beginning will be younger adults or adolescents with high risk for transplantation. Do you want to add something, Isabelle?
No, I truly hope we can find also maybe, that's my dream, to find a treatment like for CFTR modulator therapy, where we can sort of modulate the expression and secretion and trafficking of ADA2 in the cell, but that's long distance probably.
So Professor Bello,
sorry.
Yes, Professor Bello is showing his face, so it means we only have 10 minutes left. So we will going, we are not late, but we have to move on. So next slide, please. So we are arriving to the take-home exchange. So Isabelle will give her home messages for pediatricians.
Yeah, I think we should think about ADA2 deficiency with a low threshold. We really need to spread the news about this condition throughout all medical disciplines, not only in childhood, but also in adult medicine. We need enzyme activity testing and genetics, and think about heterozygous variants. You have to test them to be sure. And we don't know why some patients display DADA2 phenotype and why some don't, but this is going to be definitely important for the future. Stem cell transplant is a definitive cure. There's many hurdles we still don't overtake quite convincingly. And also be aware that there's a new study that's just been launched by EBMTC, IBMTR. So if you have patients to report, please contact me if you haven't already been contacted by EBMT yourself, so we can include you in the work. I think that's it. Next slide. And I want to highlight this consensus statement where all of us worked together to provide an update on how to manage ADA2 deficient patients. Next slide.
So I think the disease is not sufficiently known, especially in adults. So few times every year, people are addressed to us because the genetic finds the diagnosis. And especially when you dig in the file, you can see, well, it was there, but nobody thought about it, especially the ophthalmologist, neurologist. Okay, so we could have avoided many strokes. So I've already spoke about this, so I will just say the pan-like vasculitis, someone with where the classical treatment doesn't work, with the chronic inflammation, the CVID-like, and unexplained hematological features. So next slide. So I will finish by a few pictures. This is a very interesting family because this is one of the lady. She has a livedo, as you can see. She has a really hematological presentation with a mild B lymphoma. Next slide. Next slide. So this is a sister of the family. She has a very, very mild disease with no treatment, no stroke, no infections, just hypogammaglobulinemia and mild livedo. And next slide, they have the same mutations. And the brother, which allowed me to make the diagnosis with refractory periarteritis nodosa and AA amyloidosis. Next slide. This is his livedo. So it was there, and the nephrologist found the AA amyloidosis, but just he told us maybe it's genetic. I told him, get off the trousers, and he take it off, and the livedo was there, but nobody has seen it. So, and the CRP was very elevated. So let's go to the next slide. So practical steps in adults, we have to focus on the history, especially childhood fever, rashes, livedo, neurologic events, and the family history of early strokes. In the family, I showed you 3 members. They had 2 babies that were that died in early childhood, and the parents were consanguineous. The workup has to include standard vasculitis and stroke investigation, of course, and the interest of measuring DADA2 activity in the plasma, and then the DADA2 genetic testing with segregation whenever it's possible in the brother and sisters. Next slide. So it's not only a pediatric disease, and more patients are now diagnosed in adulthood after usually a long delay. And all of this we already spoke, so I will skip the next slide. So we will give very quickly in 1 minute the answers to the quiz, and then we will take some questions. You can write your question in the chat, and Alexandre will read them. So next slide, Camille. So the question very simple. So all DADA2 patients have the same clinical phenotype. This is of course false. Bone marrow failure and cytopenia can be part of the diagnosis, yes. A normal DADA2 activity always rules out false. TNF inhibitors markedly reduce the risk of new ischemic stroke, yes. Next slide. All of these were true. In children, they can present with early lacunar stroke, yes. Adults can be misdiagnosed as having Sneddon syndrome or periarteritis nodosa, yes. Adults can have a long diagnostic delay, yes, unfortunately. Most reported patients have childhood onset symptoms, yes. And next quiz. It's usually a B-allelic loss of function variant, yes. Residual activity is more often associated with a vasculitis phenotype, yes. And next and ultimate slide, TNF inhibitors are the first treatment for vasculitis phenotype, yes. Conventional immunosuppressants are not very effective. And we spoke about HSCT. So I think we can skip to the questions. And before, we have to say, and maybe Alex will speak about this, the DADA2 Foundation, which is leaded by chip chambers. You can see them on the picture, which is very active, and they are loading an international cohort registry, and every 2 years they are doing a meeting. So
Thank
next
you.
slide.
Thank you, Sophie and Isabelle. I think
Last slide.
it is finished, or maybe you have a final
Finished.
slide to the end. So
Maybe
fantastic. And it's
final.
very
Yeah,
important to finish
final.
on. Okay.
Make light on DADA2.
Okay, that's important. And thank you to these two groups. So from Leuven, I didn't mention where you are from, but everyone knows you very well. So I think your contribution and your talk was really inspiring. Thank you very much. Really fantastic. I don't see a question right now, but I can start with maybe one on Livedo. Is it for you 100% of patients with Livedo who present with DADA2? I've not seen any DADA2 patient without Livedo personally, but I'm curious if it can happen.
I think it can happen, and especially in the young children, I've seen patients with cytopenia and no livedo, and then it gradually developed. So I think it can be possible, but I would say it's very, 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 it's a very strong feature of ADA2 deficiency, but I think it's not
Yes,
sine
as
qua non.
usual in medicine, it's never 100%.
Yes,
And
and especially it will depend on the skin, because I showed you a big family. One of the sister, it was very hard to see the livedo, but I was believing it, but it was very hard to see. And also, sorry, but it's a tips. One of them is going frequently to Portugal in the summer, so when it's very tan, you cannot see the livedo, so you have to check on the parts that are hidden by the swimsuit. And also, I don't have any patients with a very tan skin like black, so I don't know if it's visible in very, very dark skin.
for Isabelle, I have a question about the immunogenic role of adenosine and deoxyadenosine. So did you tasted on your assay the immunogenicity on different TLR? I know TLR9 is supposed to be the key, but have you tasted on TLR8 or TLR7 this excess of adenosine?
So yeah, we also tested first no excess of adenosine we found in the patients, but then we tested also in vitro very, let's say, in depth, because we spent almost an entire year on testing this in depth in our patients, and we could not see a strong pattern of either down regulation of the signaling to TLR7 or 9 or upregulation. We also tested in PDCs, type 1 interferon productions, and we could also not find after let's say CPG stimulation, the pattern that has been described. Now, having said that, PDCs are very tricky to handle. So I acknowledge what has been found, but I think, we need it's very difficult to say anything. But we found a cloud of results in terms of cytokine responses that I could not trace down to any sort of action. But to be honest, it was one of my initial ideas on ADA2 that it would also work because of the nucleotide recognition area in the dimer, that it would have some function on the DNA or RNA. So I'm a believer of the hypothesis, but we need to see it more clear.
And would you recommend to treat all patients with hydroxychloroquine when it's missense mutation? And I am really seduced by the fact that you want to target the protein level itself, as is done for cystic fibrosis with a really successful treatment. So I see the parallel between your strategy and the one that has been developed in cystic fibrosis. So for hydroxychloroquine, would you suggest to start with this treatment?
For missense mutations, I would, because all of the variants we tested, we saw the same pattern. And mostly doesn't harm. Of course, you have to take into account the potential side effects and so on. But I'm not convinced that it would not. It's not gonna harm more than any other drug you would add, or more than a stem cell transplant. And so in the patient we started it on, we were with our back against the wall. So Is it going to work for all patients? Probably not, as again in medicine, but would it be a good thing to start and to try? Yes, because I believe that maybe in these patients we will need to go to a combination treatment and not only rely on anti-TNF. And I do hope that we find a modulator that can do the same as for CFTR. Frankly, if you look at the data out there, it should be feasible. We just have to have a lot of money and let's say ideas to work on that.
So we have comments and questions. So one is a comment on the fact that Carrie mentioned that they published a case with the ET CCR1 mutation treated by bone marrow transplantation. It seems to be okay. And Livido was cured by the bone marrow transplantation. There are some questions about, but my Spanish is not perfect. Is there any information about the enzymatic replacement? Is that possible? We know it's possible for ADA1 deficiency, and it was an hypothesis how we could restore the ADA2 enzymatic function.
Sophie, do you want to comment?
No, go.
So you might probably know that that the ADA2 there was a patent with a company that wanted to have ADA2 with increased function to treat leukemia. So they wanted to direct this molecule to the tumor microenvironment, but it never set off. And so I know that now Chip Chambers is very interested, and I think they have obtained the molecule patent, and so they are really investigating this. Of course, it would make sense to do it. I also see a lot of complications, potential complications with the treatment. It would need to be transported into the cell, probably, if we think about the lysosomal hypothesis, be processed and so on. But I think it's feasible. It's going to cost a lot of money as well. No doubt, but I think it's feasible. There's only, I think, one little caveat is with there's this paper on NASH and ADA2 where they show that actually too much ADA2 plays a role in inflammatory conditions in the liver. So it will probably need to be fine-tuned to have the optimal dosing again, as with ADA1. But I think it's feasible, but it will need some more work, just as the gene therapy.
And we can also add that the half-life of ADA2 is very short. It was shown with plasma replacement and measurement of ADA2 over the time, and the half-time is very, very short. So possibly in the case of emergency, but it needs to be changed and pegylated or something to keep the protein at a good level for a while. I think we are done in terms of timing. So fantastic. Great talk, both. And thank you again for this fantastic presentation. Thank to the audience, because there were a number of people who joined this first Lunch with Rita of the year. So thank you very much. We are excited to the next step. So next month, there will be a Lunch with Rita, first Tuesday of the month. You're welcome. And if you have some ideas to cover, if you want to participate, please just ask and reach Camille. So bye-bye. Happy New Year again. And see you next month.